Welcome, everyone. We got a great guest today. I'm really excited because we're going to be talking about borderline personality disorder. Before we get to that, make sure if you want to support our podcast to share and subscribe. Hey, if you're listening on our audio, you can also catch this on our video. Our new channel, Circle of Insight. Look it up, Dr. Carl's Circle of Insight on YouTube, and you can catch some of our videos. If you enjoy the psychology bent, definitely you'll like this video. But before we get to that, Dr. Daniel J. Fox is a licensed psychologist practicing out of Texas. He specializes in personality disorders, and he's also, you can find him at drdfox.com, drdfox.com, where you can get more information about him. He also has a channel on YouTube, so definitely check it out. Let's not waste any more time, and welcome to the show, Dr. Fox. Welcome, sir.
Thank you. Thanks for having me. I'm excited to be here.
Thank you very much for being here. So this is a fascinating topic. Just like we were talking about before the show, there's a lot of misconceptions now about borderline personality disorder. And before we get into that nitty gritty, tell us a little bit about the etiology. How does this originate?
Well, so the term borderline personality disorder, so it comes out of actually a misconception of sort of the border between psychosis and stability, so to speak. So what you had early on is that you had folks who couldn't contain themselves emotionally, tended to be overreactive, and they weren't quite falling into that psychotic area, the schizophrenia, things of that nature. But you had folks that were, again, they were on the border of that because of the expressiveness, because of the volatility. And what they said, well, these folks are on the border. So that kind of took off over time. And then really sort of that DSM-3, 1980, when that came out and all the criteria came out. And so, with borderline, they certainly, defined some of that criteria, and it's continued onward from there. And I think, as it's grown, so have the misconceptions, which you alluded to. And I think it's become more problematic. I think that, and it's become this sort of this stigmatized label, I think, that a lot of folks get stuck with, and people forget, that it is on a continuum, that it is on a spectrum.
That's one of the things I always tell people all the time is that, if you're going to learn about mental health disorders, the newspapers aren't the place to go. And the news isn't going to be either, because they're just looking for, and I get it, they're looking for their clicks, whatever. So that's going to be a whole different ballgame. But like you said, it really causes a lot of confusion out there. How about in regards to the developmental cycle, how does that play a role? Because a lot of people argue nature versus nurture in regards to borderline personality disorder. How does that work?
Yeah, so there is a heritability component to it. But it's important to remember so that all personality disorders are made up of a combination of traits. And all of those traits have different heritability. So to say that borderline personality disorder, what you're really doing is you're pulling together all of these traits, emotionality, certainly reactivity, certainly temperament, other factors. So they all have varying degrees of heritability. And when we look at sort of overall in a lot of the studies, you see that a lot of them are right around 42% heritability for borderline. And of course, that comes out of, having a close parent, family member that also, qualifies for the disorder as well. So of course, that there's so much of an impact in the environment as well as to how that person responds and how they're, model after that adult or caregiver. So they learn that behavioral response, they learn that emotionality. That was one of the things, Linehan, she did some really amazing, Marsha Linehan did amazing work actually. She talks about the family dynamic. She talks about these family components and how these kids who grew up, and sometimes I'll refer to them, whether it's with my students or with clients or other mental health providers when I'm doing seminars, is that they're the fledgling borderlines, right? And, the fledgling borderline individual, what happens is that, they're in this environment and they're having emotional expressions, as all kids do. Well, the problem is that these parents, what they do is that they see and they blame the child for the emotional response, or they just completely neglect the emotional response, or it becomes this massive overreaction to typical childhood adversity, right? Typical childhood experience. And that over time tends to mold the individual to what we later in adulthood, what we would ascribe to as borderline personality disorder.
Oh, fascinating. Now, I know I've read articles in the past, and some people will say that a lot of them come from abusive homes, whether it's neglect, physical abuse, sexual abuse. How accurate is that?
Yeah, I think the problem with that is that I think that the misconception is that all individuals along the borderline spectrum have experienced, some type of abuse, physical, sexual, emotional, psychological. There is certainly a preponderance of individuals. So myself, in addition to my private practice, I also work in a federal prison. So there, we see about 85% of individuals that fall along the borderline spectrum have experienced some type of sexual or physical abuse. And that sort of transcends gender as well. And that's a big misconception. And it's even wrong in the DSM-5, which is that they say that it is about, 3-to-1 female when you talk about a gender ratio. But the reality is that it's actually closer to about 52-48%. So 48% male, 52% female. But again, it gets perpetuated. Why they didn't update it in there, I don't know, because they're familiar with the research. They know the research. Why it's not in there, I don't know. But of course, in the DSM-5 now we have those 2 personality disorder models. Okay? And one of the books actually that I just put out earlier this year, what I wanted to do is try to bridge that gap between the alternative model of personality disorders and what I'm calling sort of the classic model, right? That the section 2 model, which is what we're all familiar with, which is those criteria, so on and so forth. And my approach and my conceptualization and the way that I was taught actually 20 years ago, Carlos, it's been a while.
Yeah. You started at age 10 then, okay.
Yeah, right. See, thank you. Is that, is one of the issues, and certainly from a treatment standpoint and a diagnostic standpoint, is seeing personality disorders as a linear construct, which is that you see personality as personality. And it's really not. It can't be conceptualized like that because it's a dual construct. So, you have your bottom layer, which is your core content. And then you have your surface layer, which is your surface content. And that's how I've described it in like all of my books and things like that. And now in this alternative model, they're using those terms. Did they rip me off? I don't think so. No, I'm just kidding. But, right? But they're using that same terminology. And I think that's because we're realizing that, in individuals with borderline personality disorder, we know about that high preponderance of comorbidity, right? We know that pure BPD, and that's actually my current research area, is looking on what I'm calling complex BPD, complex borderline personality disorder, which is looking at not only the 3 to 13%, which is pure BPD. That means that all of those symptoms, all of that surface content, that depression, that psychosis, that ADHD, that those PTSD, those complex PTSD, symptoms that we see right in our treatment centers and in our offices when we're working with them. But underneath what's driving a lot of that, and bipolar disorder, 25% of all individuals, with bipolar will also meet criteria for BPD. So, and then we see that bipolar disorder. But so we look at that surface content, but underneath is that borderline, is that sense of abandonment, that sense of emptiness, and there's no medication for it. All right. What works is treatment. What works is, using a lot of components like DBT components, transference focus, which I like that as well, schema therapy. There's all these efficacious treatments for BPD because it's a treatable disorder. So going back to that conceptualization is, depending on what surface structure we're seeing, whatever that comorbid condition is. So for example, if it's bipolar disorder. So bipolar disorder, if you're trying to treat the borderline personality components, let's say of abandonment, but that individual also goes into manic phases and depressive episodes, and you can be sure that they're actually episodic and they qualify for bipolar disorder, you have to treat the bipolar disorder first. Otherwise, it's going to continue to get in the way as you try to get to that core content of abandonment. So you have to first get those episodes, those manic episodes, depressive episodes, treated as best you can with the medication. But herein lies kind of the complexity of BPD when it's comorbid with bipolar, which is that all individuals with borderline personality disorders, I shouldn't say all, I'll take that back. The majority of individuals with BPD also experience what are called depressive episodes. Those depressive episodes don't qualify for major depressive episodes. They don't. But you see these individuals with BPD that they have these downward trends, these hopelessness trends, these worthlessness trends. But the challenge is for you and I as psychologists and treatment professionals is that, okay, so is this a depressive episode or is it a major depressive episode, right? So which is it? And we have to tease that out. So once we get, if we go back to the treatment example of bipolar and BPD, once we get the manic episodes and major depressive episodes stabilized, and knowing that we're still going to have some depressive episodes, that then we can start to work on the core content. But getting to the core content is protected with your defense mechanism, which is rage, acting out, cutting. It can be a sense of very coquettishness, depending on what those defensive mechanisms are for that individual. So the therapist has to build that in to their treatment trajectory. This is not the client who talked about, frustrations at work last week, and you're like, oh, okay, well, Jennifer talked about that last week, so, then let's see how Jennifer's doing this week. You can't do it with these clients because there's too much inconsistency. There's too much erraticness. I'm going to create a word if that's okay. So this sense of erraticness, right? So what you need to do is you have to plan a treatment trajectory. And if one of the brilliance of DBT is that Linehan knew that not only did you have to add a component of mindfulness, right, to detract from that sense of dissociation, but you have to have treatment trajectories. You have to have plans for how you're going to work through these issues. Gunderson is another individual from McLean Hospital in Boston, which we were talking about him before we started. And he knows that as well. He knows that, structure is critical because that is what these individuals need. Yeah, they're going to have issues that come up, but they're very thematic in that, it tends to be a sense of, the individual that's involved, or sometimes, the environment may be different, but it's always this issue of, let's say, loss, abandonment, feeling rejected, victimness. So, knowing that that's what continues to arise, how do we deal with that? And Linehan and Gunderson, and what I think is they're both amazingly just brilliant human beings, and Gunderson, of course, has since passed away. But Gunderson, he said, the true component of BPD is this lack of meaning and purpose. And, in my clients that I work with, kind of regardless of where they are along that spectrum, whether they're extreme, or it's more of a mild form of BPD, is that you see that there's this lack of meaningfulness. There's this lack of purpose. And then when we go over to Linehan is that, that core component is this radical acceptance, is that you can't fight the tide. You're not going to turn the tide because you fight the tide, you're going to get wet. But if you expect to fight the tide and go in the ocean and say, well, I'm not going to be wet, I refuse to be wet, but yet you go in the ocean, you're in a constant battle that you can win. You have to accept the situation where you are. It's radical acceptance of the situation you're in. So for my clients, what I try to do is I try to build in this sense of radical acceptance while they seek out meaning and purpose in their life. And it takes a very long time because not only are you unlearning these maladaptive patterns that are surface content, while we're trying to rework core content, which goes to old patterns. And Lorna Smith Benjamin, she talks about what's called family in the head, right? These are those individuals that we've internalized from our developmental period who told us, all these horrible things about ourselves, right? All these characterological attributions because we, spilled the milk, or because we didn't, have 5 home runs in our baseball game. We internalize those messages, and that becomes that family in the head. And we have to take apart that family in the head. We have to accept where we are while we're building meaning and purpose. Whew, it's easy.
That was great. You almost wiped out a lot of questions.
Sorry about that.
No, that's great. That's great. Folks, by the way, the book is called The Borderline Personality Disorder Workbook, an integrative program to understand, understand and manage your BPD. That's the newest book, I think, right?
Yes. Yep. And then I have one coming out in January of 22, and that's that complex BPD. And so we're also going to have a clinician's guide that comes with the book to really, So New Harbinger has been really wonderful with me in that, I proposed this idea and they loved it and they said, just go to town. And you shouldn't tell me that because I'm going to go to town. So I gave him a heck of a book, but I think, and my hope is that not only do clients and family members, but clinicians also see that we have to look at this from a larger scope. We have to look at this, that not, from that dual construct, that core construct. That's why the alternative model is so brilliant. And, as psychologists and mental health providers, we need to be using the alternative model because statistically, it puts us in a higher probability of more accurate diagnosis. And that's what we need, because we constantly, at least the folk that I see, is that I see folks that have bipolar disorder are misdiagnosed with borderline. Or I see folks with an impulse control disorder, and they tend to be female, that are misdiagnosed with borderline. But males that are actually have borderline personality disorder, they are actually misdiagnosed as antisocial. And that's a problem that we really need to start breaking up because it's massively problematic, particularly in the justice system, because antisocial, depending on the severity, is not treatable. Right? So we don't have really, we don't have DBT, there's no DBT for antisocial, right? But borderline is treatable. These folks are treatment seeking. And the problem is your antisocial individuals along the antisocial spectrum, particularly if they're moderate, high moderate, extreme, or severe, they don't want to do treatment, right? They want to do treatment for the secondary gain. But your borderline clients, depending on their level of motivation, which is so critical to know and assess, but is their level of motivation is they are treatment seeking. They do want to do things differently. They do want to learn about themselves. They want to build that meaning and purpose. We have to add in how to do that while we teach them about radical acceptance.
I got a lot of questions for you now. So again,
Okay.
It's good. It's good. The book is called The Borderline Personality Disorder by Daniel J. Fox. Dr. Fox, I was going to ask you, I had to go way back to the earlier part of the interview in regards to prison, but you brought it up, so it reminded me back again of the question. You mentioned continuum, but then you also mentioned like 85% of the individuals of the people who had BPD in the prison systems had all of the traits. So that's the continuum you were talking about, right? So this select group obviously go way above and beyond the other group who don't have all those traits. Is that an accurate assessment?
All the criteria. So the folks that I'm talking about, that 85% is that they do have the, if we're using the Section 2 model, the more classical model, is that, so they would have those 5 criteria. They would meet those 5 or more criteria. Whereas we talk about those with BPD traits. Now, if we talk about females in the judicial system that are incarcerated, we're also talking about 85% that have experienced sexual abuse. So, how to tease all that out again, then I think we would get way off course as to what we're talking about here. But yeah, so even those, with BPD traits, and then we're talking about the incarcerated individuals. But I have seen, of course, on the outside, because I also have a private practice as well, so I see non-incarcerated individuals, is that, even with BPD traits, I think that we can't say that abuse of a variety of different sorts equals BPD. We never want to go there. And as I've trained other mental health providers, I've had them say that, well, all borderlines have experienced abuse. And it's like, whoa, no. First of all, that's just not true, right? I mean, we know of all the individual, variability of our clients, We know that, right? Of the diagnostic spectrum and things of that nature. So, there's so much variability, but no, all of them have not. There is a high probability of those that have, in varying degrees of abuse.
Oh, I was going to say, that's the interesting thing is I tell exactly the same thing to everybody too. It's the word all or everyone should be eliminated from the social science world because there's nothing in the social science world that's absolute.
Right.
Yeah, no, that's a great point. Great point. My other question is, I guess, how was the comorbidity? And I can't remember. I don't think it was Gunderson. I think it was somebody else who deals. I don't know if you're familiar. There's a guy down in, I think it's San Diego, who deals with legal conflicts and BPD. That's what his area of specialty is. So he works with people who have trial issues because a lot of them, I guess, do get involved in litigation issues, at least according to him. But he was saying there is a comorbidity of about 25% with BPD and antisocial. What do you think? I think that's high.
25%. I mean, see, the problem is that is that they have those clusters, right? So you got your cluster A, your cluster B, your cluster C. So cluster B, and actually, interestingly enough, is that those clusters are really they weren't really scientifically created. It was more on the topology. It was more of, well, erratic and dramatic. Well, you're narcissistic, histrionic, antisocial, borderline, boom. Well, they're kind of similar, so let's all lump them together. And then your paranoids, right? Your schizotypals and your schizoids. So lump all those together, there's your A. And then so on and so forth. But so when we talk about that overlap, what I say, 25%, I haven't read anything where it's been that high. But I think that it can be quite problematic when there is that combination of borderline and antisocial. So I can say in my, almost 20 years in the prison system, the state and federal prisons. So the clients that I've worked with, or the individuals that I have worked with that have met criteria for borderline and antisocial, I have really deep memories of those individuals, but they're very rare. They're very rare individuals, and probably because either, the over emotionality, right, gets them into fights where they're killed, or, the antisocial and the impulsivity associated with that. So it tends to be a more lethal means. So they probably end up completing suicide at a higher rate. But again, I don't know. I don't know if there's actually research on that. That's just more a clinical speculation. So I don't know about 25%. I would say that would seem high to me.
He might have been doing the same thing. He might be doing it off his own samples or something. I don't remember.
Yeah.
Yeah. No, it was an interesting thing because I thought, wow, 25%, that's pretty high for BPD and antisocial.
And it is, and there's such a misunderstanding is that, as we talked about before, I mean, and I won't say who it was, but there was a mental health professional, who made the statement that borderline is the female equivalent of antisocial personality disorder. And it was actually that comment that actually drove me to start my YouTube channel. Because I was watching something and, so I'm 50 years old. So it took me a while to catch on to YouTube, right? So one day, but I've been working with personality forever. I'm like, I wonder if there's BPD stuff on YouTube, right? So I type it in and I'm looking around. And there's this guy and I'm like, Dr. such and such. I'm like, okay, well, let me see what he has to say. So I'm watching him lecture. And, he's lecturing about, different psychopathology issues, things like that. And someone from the audience, the dark audience, right? And he yells out, what about borderline? And then he makes that statement, that borderline is a female equivalent of antisocial. And I was so disgusted because that is old, antiquated data. That's 1970 data. And we can't be putting that out as mental health providers. As experts in our field, we can't be putting out 1970s data. We've got to look at, how about 1993 data, right? That's when, DBT
still 30 years ago.
Yeah, still, right? But why don't we use that? But to say that was, I think, so harmful. So then what I did is I made a choice. I said, you know what? I'm going to make a video, put it out there about why clients or individuals with BPD should have hope. And, before I put it out, I thought, man, I'm just going to get ripped from one end to the other about this thing. The people are just going to tear it up. And surprisingly, a lot of people wrote that couldn't afford treatment. A lot of people wrote they couldn't afford, to understand what's going on with them. Or a lot of people, they didn't realize that BPD, whether it was in their loved one, significant other, children, whoever it was, friend, partner, coworker, that BPD wasn't this horrible, all the Glenn Closes. See, I'm 50, so I can say all the Fatal Attraction Glenn Close, or all the Gone Girls, and Gone Girl, she's the antisocial BPD, combo. But, or Girl Interrupted, I think was another one. But, all of these things that, so these folks were writing me and saying, my God, and it's everything that I talk about is based on data. It's not just my own clinical experience, it's based on data. So any video that I put out is based on the data that I have found, and some is clinical experience, and I always say that, but I think that for myself, being a licensed psychologist, I think that it's my duty to put out information that is based on research and not just my opinion or, just my clinical experience. I think that the data is so important to prevent things like that from those views being perpetuated, and that is a stigma that is really hard to beat.
You're absolutely right. It's very complicated because people still, you hear every so often where people just that person's borderline, and I just fling this one thing. It's like it's like, whoa, you haven't even talked to the person longer than 5 minutes.
Right.
But yeah, like you said, it's in the nomenclature now of society. So certain ones, like everybody's a psychopath, everybody's schizophrenic, everybody's got borderline. That just those all bipolar.
Don't get me started on psychopathy. You don't want to get me started on psychopathy. That's a whole nother road. Yeah.
That's I know. That's another one. I want to take you back a little bit. I know we got about 10 minutes left, I think. But I wanted to go back a little bit because we talked about abandonment. That's something that's always associated with BPD. A lot of it is abandonment issues. And it brought up Bowlby for me and attachment theory. And I also wanted to tackle Frankl a little bit because he also mentioned about hope and having a purpose in life. And I know Frankl's got that great book. But let me start off with Bowlby. So what's your take with attachment theory? Does it work? Is it a good way to conceptualize them, or does it interfere with DBT?
Yeah, no, I think that attachment is part of this process. Is that, first of all, right, that, individuals with BPD or even with BPD traits, that they are treatment seeking. So in that they are treatment seeking, right? So they're going to come into the office, you're going to start working with them, things like that. But they're going to attach. If they see you as that safe object, now we'll add some object relation stuff. So now that they see you, right, as this safe object, then they're like, okay, maybe this is somebody I can trust. And what they do is, and the way I describe it in my seminars to other mental health providers is that, and this isn't derision, this is just more for example, which is it's like taking a 2-year-old, to the playground. Right? So you take your 2-year-old to the playground, right? At first, they kind of stay by you, right? So at first, your client with BPD is showing up regularly, and they're showing up pretty consistently. You're having some ins and outs, but no explosions or anything. Then, right, we'll go back to the child at the playground. That child goes off and meets some new friends, tries out the slide, tries different things, stuff like that. And then he comes back to you, right? The child comes back to you. Your BPD client then says, I know showing up, and this isn't conscious, this is more reflexive. And I think, again, another issue is that I see a lot of my clients are blamed for a lot of their surface behaviors, saying that, oh, well, that was on purpose. But if you look at that, it's really reflexive. It's really, it's this reflex, this defense reflex, this maladaptive coping strategy to get them through life, right? So again, what happens is then they're like, okay, well, I'm going to miss a session. I'm going to ditch and see what happens. So then they ditch, right? And then you're like, oh, well, they're not showing up, okay? And then maybe they'll skip 2 sessions. Then they show up. That's the playground. And then we get upset at our client and it's like, well, you have BPD and you're missing. See, that's just BPD. That's your 2-year-old on the playground. That's attachment at work. That's what's happening. Now, the way that I beat that with my clients is that I get ahead of the game. How do we get ahead of the game is when that first session we talk about that, they're allowed 2 misses. Now, and they're usually like, what are 2 misses? I said, 2 misses is that you're allowed to miss 2 sessions, right? And you got to let me know 24 hours in advance because I got a wait list, right? But if you miss 2 sessions and I don't hear from you, right? Well, first of all, if my clients, depending on the severity, of course, we do welfare checks and the sheriff's out to the house. But aside from that, so you get 2 no-shows. So you do 2 no-shows, we're done. And the one thing that all of my clients know about me is that if I say it, I mean it. So that there's no real, and it's not a matter of being, kind of like a tough guy. You can see me, I'm not a tough guy, but there has to be fairness. There can't be any can I trust this guy? Who is this guy? So there's that sense of that if I say it, I mean it. And as we go through it, through our agreement, in the 2 sessions, I got to cut you off. Now, that doesn't mean I won't see you for the rest of your life, but that means someone's going to take your slide. Because there are other people that are waiting. But what's interesting is that ever since I started doing this, missing 2 sessions, whether I'm in prison or I'm out of prison, you know what I mean, right? But whether I'm in prison or I'm out of prison, is that my clients don't miss. They don't, because, I think that they recognize that there's value in showing up, that I have taken away that nervousness associated with the attachment component. And also, I think that they know I'm on their side. I am such a cheerleader. We'll go back to some DBT Linehan, terms, is that, that I'm such a cheerleader for my clients, that, my job is to help them get what they want. Because what individuals with BPD want is the same thing all of us want. We want love, respect, reparations, appreciation, right? But the way they go about it is so maladaptive. But if we can replace that with meaning, purpose, and if they can incorporate radical acceptance, and those other components as well, behavioral control, so on and so forth, they can turn their life around. And I've had clients for 4 years, 5 years, and they were extreme BPD, right? Which is really only, by the way, about 3% of all individuals with BPD, but people with BPD are massively misunderstood, because as soon as you have BPD, you're a Glenn Close, you're an extreme case, you're a Gone Girl, right? You're Girl Interrupted. I hope that's the right movie, but right, but you're that extreme case, but that's not the reality. But my clients that I've worked with on the extreme end, cutting, kicking my door to start session, throwing a chair at me, I've been spit on. I've had just about everything is not tied down in my office chucked at me at one time or another. But the reality is that 4 or 5 years later, working through these things, keeping that relationship, keeping steady, saying what I mean, meaning what I say, being a cheerleader for them, purpose, meaning, radical acceptance. 4 or 5 years later, if you were to hear from any of them, you would say there's no way that you qualified for BPD.
Let me ask you this, and for my psychoanalytic fans out there, as you were talking, that's almost like a technique in itself, giving them that 2-session warning, because you're giving them structure, as you mentioned really early on, was really important, right? So it becomes almost like a framing, as the psychoanalyst world love to use, right? Yes,
absolutely. And I tell them, that we need to frame going forward. So sometimes what I'll do is I'll do a 10-session plan. And these are things, that these are little, I don't want to say milestones, but they're little goals, right, that I want to make, which will be, so like radical acceptance. So we'll find a radical acceptance worksheet, and I'll be like, okay, when you have situations where you're overwhelmed or stressed out, do this worksheet, fill it out, okay? And the next time we meet, we'll process it, go over it. And that is, so that is building that radical acceptance, building that sense of understanding. It's building this new sense of conceptualization. And what happens is, so as we go through the sessions, so session 1 is, teaching them radical acceptance, and, familiarizing them with the worksheet. Session 2 is, okay, going over that. I think too many times, we're all so busy and we have so many clients and caseloads and things, we forget to go back to the homework. We forget to go back to, and I try to avoid the H word, I like to say out of session activities. So, but anyway, right. But I always make sure to go over it, or, I ask them to review it, and then, and then we review it together. Then the next session. So I plan out 10 sessions. That's structure. Then the 11th session, we're creating another 10 sessions of what are our goals to get through this. And it provides them a sense of structure. But what does structure do for children? Provide safety.
Yeah.
Yep.
Absolutely.
And that's what these folks need. because there's so much variability. There's so much derision in their life that without this sense of structure, right, just coming in and talking to you is not going to do it. I'm going to espouse 1,000 things in that 50 minutes or 55 minutes. By the way, with my clients, I always go a solid 60 minutes, right? So, yeah. So, I mean, I want to give them the maximum, right? Amount of time, but I cut them off at 60. But, because I think it's that added bit, it's that added component. And my goal is at the end of session is how can I empower you until I see you again? But the other component, and John Gunderson also, mentioned this as well, once a week is not enough. You're dealing with a client who needs anywhere from 3 to 4 sessions a week.
Oh, wow. Really?
Yeah. So I do have clients who can't afford that. So what happened, not in the prison, because the prison, obviously, they don't pay for it, but out in the community. So sometimes what I'll do is that, we'll have one session and then we do 2 sessions that I call adaptive response sessions. So that may be like a 20-minute phone call. And we're talking about using those adaptive skills. We're talking about using that radical acceptance. We're talking about, and we're not going to get into the nitty gritty of it because that's session work. So we get into the adaptive components in those sessions, and I don't charge them for that. So I mean, yeah, I mean, I have some of my colleagues say, so you're giving it away. I said, well, I don't know if I'm giving it away. I said, but if it's something that I can do to help somebody, do their life different. And I'm very fortunate though. I mean, I've got a foundational job that provides for me very well. So it provides a degree of flexibility. But I think those 20-minute sessions are critical because if you just do once a week, they're spiraling, for those days until they see you again, and then you get an avalanche. So avoid the avalanche.
Does it taper off from 3 to 4 times a week? Does it start going down to 2 or 3 times?
It will. Once you see some stability, then you find that they don't have much to talk about. Then they start saying, and then they start saying, hey, you know what? Maybe I don't need to talk to you on Mondays. Maybe we'll just do Wednesday and Friday. Yep. And that's when you start to see that, and you start to see that adaptiveness, but also I remove myself as a dependent object for them as well. Is that initially there's a lot going back to that attachment, very dependent. It's very, I couldn't make a decision. I had to talk to you first. And then we talk about, a lot of my clients are good decision makers when they slow down and reason it out. But once that surface content, that anxiety, that PTSD, those other issues start driving that impulsive behavior to make decisions, they make really bad maladaptive decisions.
It's fascinating. I know I used to be a big solution focused CBT fan, and I still like it a lot, but I've switched over a lot more to Jungian theory. And it's funny because I started conceptualizing through that model a lot, and just listening to you, and when those things surface up and the walls come up and they have that little persecutor protector in them and they start putting the resistance against you, or I think her name was Dr. Seif, I think was the one who said, I don't know if it was Dr. Seif or Dr. Crossan. They deal with trauma, but they came up, they don't like resistance. They like, I think it was protection, to protect themselves, right? When you tap into that area, they have to be ready to be able to handle that stuff, correct? Right.
Yes. And which is why skill building has to come first. There's a great article, and I can't remember the researchers, but what they found is that if you start working on skill building session 1, whether it's mindfulness, whether it's DBT components or it's building insight, but if you start skill building, session 1, you significantly decrease inpatient self-harm and hospitalization.
Wow, that's a lot.
Why are we waiting till the 3rd session to do it? I don't get it. We need to start doing skill building session 1. And with individuals along the BPD spectrum, our stock is so high with them. Oh, the sun is coming through there.
You were saying?
And yeah, so what it is, it's this, these components, and it's giving them these skills, and not waiting until session 3 when we do our treatment plans to then say, oh wow, you know what, we really need to do some adaptive options for this person. No, we need to start that first session. With all my students, the first thing I tell them, I want you to pick 1 or 2 coping strategies, and I have like dozens of workbooks in my office. And I say, go through the workbooks, look through them, find some that fit for you with your style and your approach. And then master 2 of them. And you're going to teach those to all of your clients, session 1, and you're going to revisit them till nauseam, because that's how we learn, right? Therapy is like roller skating. The first time you do it, man, are you going to fall on your face, right? And that's for the client too. It's building those skills, but the more you do it, the better you get at it. And adaptive skills are the same way, right? It's unlearning bad habits and it's learning good adaptive habits. And if we stick with our clients, we'll hit that 80% remission rate. And I mean, and it's just absolutely amazing. We can absolutely do it.
I could be here all day having this discussion, but we're running out of time. Folks, again, the book is called The Borderline Personality Disorder Workbook. Daniel J. Fox. Daniel J. Fox, you can get it there. You can also find more information about him at drdfox.com. Thank you so much, Dr. Fox, for being here. That was great stuff.
Yeah, no, Dr. Carlos, I appreciate you having me on. This was great. Thank you. I really enjoyed it.
A lot of fun, a lot of great stuff for everybody out there. Folks, again, you can catch more of the other episodes on Psychology Tidbits if you're on the audio. If you're on the video, you can catch us at Circle of Insight, the Dr. Carlos Circle of Insight on YouTube. Make sure to share and subscribe. Thanks, everyone.